I'd now like to introduce Leah Biziani, registered nurse, with a Master in Health Sciences, and she's a dementia consultant. She's going to be talking to us about exploring the nature and treatment of chronic pain in the Australian aged care setting. Leah Biziani is a registered nurse and dementia consultant with more than 25 years' experience in aged care. She has a Master's in Health Science. She's a strong advocate for the rights of people living with dementia and has received an Excellence in Innovation Award for her person-centred and behaviour management models of care. Leah is the Managing Director, CEO of Green Sea Medical Proprietary Limited.
I'm not anymore.
Well, she's not anymore, so we'll leave it at that. But look, I just wanted to share with you, as you can see, this is a lady who stands out, you know, and a little bit of rebel in there, I think. But she was explaining to me last night how her grandfather, who was born and raised in Poland prior to the war, could see what was happening in Germany and realised what could well happen and tried to talk to all of his siblings and relatives about the need to get out of there, and they all shut him down, a bit like what happens here when we're talking about something like medical cannabis. But he had the courage to follow his convictions, and he got out of there and he took his 8 kids with him. And within a couple of weeks, the rest of his family had been eliminated. So, and I feel like his genetics have somehow fallen to his granddaughter, who is an absolute warrior for caring for people and making their final years something that's easeful so that they can pass over in peace. So please welcome Leah Biziani.
Thank you, John. You're very kind. Let me just get my notes. I won't be using notes all the way through, but it's a good way to start. Welcome to the third day. Can everyone hear me okay? Of the United in Compassion Symposium and our wonderful journey into the green, where we continue to delve into this really refreshing and innovative and phenomenal, see, I can't even talk right now, I'm too tired, benefits illuminated by our peers in the last 3 days, directly responding to the long stigmatised attitudes and undesirable perceptions held by a vast number of our population. And this is all in regards to a very simple plant and that we're looking at, medicinal cannabis. First, I'd like to thank Lucy Haslam. I'm not sure if Lucy's in here, but I would like to thank her husband Lou, United in Compassion representatives, for providing us with such an exemplary and inspiring 3 days and forum for us to share some very provocative and crucial information together as one regarding the therapeutic use of medicinal cannabis and putting the focus back onto the patient. Briefly, as mentioned, my life's work has been focused within the aged care in Australia, specifically looking at people living with dementia and creating environments in which they can thrive. And my work has taken me to the Global Forum, which has been a very exciting experience for me and a wonderful journey, and a great catalyst to change. So I know that with the courage of our convictions, we can create change, and we can do that with great strength. We need to challenge the old malignant philosophies and cultures of care within the medical industry. And I've spent my whole life dispelling a lot of those myths associated with specific areas of need. I'm using that leverage now with the emerging medicinal cannabis industry to challenge that stigma that has been propagated, that is related to those very still negative stereotypical viewpoints fostered by the judgmental perspective of society, and often don't actually reflect in any way the reality of the people that we care for. Consider the present alternative, which is we continue ignoring the significant benefit of cannabis and refuse to contemplate the countless areas where traditional medicine is ineffectively managing critical conditions. Are we not then condoning and prolonging the suffering of a population in need? It's time to acknowledge that the answers may be contained within this very simple organic plant. And if we don't alleviate the pain and the anguish we continue to witness, could this not be considered condoning neglect? Enough with the restrictive, conventional and conservative views when our people are crying out for support. Let's give a voice to those in need and stand up for their rights. They deserve nothing less. My belief is in innovative approaches, thinking outside the box, creating change. Well, I actually believe there is no box. So we only restrict ourselves by the walls that we build around ourselves. The medical community all supposedly enter the health profession because we follow an underlying and significant code. A belief in the alleviation of the suffering of humanity. Does not the Hippocratic Oath suggest do no harm? We are supposed to come from a place of empathy and compassion, or as I say, passion with heart. I have a little quote here, which actually I think is a nice one, so I'll read it out to you. Empathy is seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another. Because unless we see life through the eyes of the people that we're meant to be caring for, we can't actually care for them appropriately. It's our responsibility to benefit our people and provide them with the answers to the identified problems and recognised conditions that aren't responding to traditional medicine. We should aim to make a difference to humanity and honour that promise. There are hurdles. We have been talking about them for the last 3 days, but despite that, the seed's been planted, figuratively as well as literally, and there is no going back now, and our vision is now becoming more tangible by the moment. It's not a negative dream, so it can't be negated any longer. It's not fanciful, so the excuses aren't relevant anymore either. It's real and it's positive, it's logical and it's humane. It takes time. But be patient, my friends, because making dreams a reality and anything worth fighting for does take time. But remember, there's power in numbers. And those numbers are now becoming a lot vaster than what they've ever been. So let's continue to inspire each other, become an ever-growing powerful voice, encouraging a solid and robust duty of care that should be, at the very least, a baseline expectation within our medical community. Let's reveal the truth and lead by example, proving that we do have the answers to alleviate the suffering and that there is a better way. Let us be the medical leaders with a research portfolio that cannot be questioned. Let us speak with empathy and compassion, and through evidence-based research and minimising risk, prove the doubters wrong. Many valid and pertinent points have been brought up in the last few days, and I have found that there are 4 key areas that I would like to address just quickly before I launch into the presentation on our research, our clinical trial, because I believe this will secure a lot of power and strength that we need to kick through this quagmire. Jumping up and down and saying this is how it should be actually creates unrest, resistiveness, and drags out the suffering of the people that we're trying to assist here. Playing the game better than the game players is how we get results. To do this, we need to be very smart in our approach. We need to know more. We need to not be sloppy in our research and our clinical trials, because that places people at additional risk. And if we place people at risk and something goes wrong, then immediately we'll be jumped on and everyone will say, see, you're right. It's not going to work. So if we minimise all risk and give safe and effective treatment and back it with clinical research, then we have sufficient ammunition to show this process up as the sham that it truly is. Thank you. I have listened and digested a lot over the last few days, and I can't see why the following processes, if implemented correctly, shouldn't create a situation where we can achieve the outcomes that we desire. Politics, bureaucratic red tape and money may be relevant, but I believe the bottom line is those in power are ego-based. So if we look at the people in the public eye, they don't appreciate to be made to look foolish. So let's shame them into submission by what we do. So the 4 areas I've looked at, the first one is education's been something that's been spoken about quite a lot. The other part of what I do is education, so I'm a very big believer in knowledge. If prescribers in society lack education, then we create that framework that enables up-to-date and correct information systems. We reverse that stigma associated through ignorance, and we make it clear that we're promoting a medicine, and there can be no associations made to, for instance, the street version of cannabis, because that stigma still exists. Feeding fear based on sensationalism and lack of fact is what the media do really well, and they're still doing it. So facts presented by respected professionals, patient advocates, all of the people in this room and all of the people that are actually flying the flag for this will reassure the community and the medical profession. We can't expect the average person to know as much as we do about this area unless they're actually directly affected by the need. It's like with any condition. Until you're affected by it, you actually don't know the processes. So it's like anything, we need to commence educational programs for healthcare professionals and the community. This is already happening. I've been working with certain people that we're already talking at or speaking and presenting at hospitals, medical forums, community-based forums, and giving them education but also correct information. There's more that are being designed, and offering Australian-wide advocacy groups as we speak are doing the same. One of them is the Canteen Leadership Program that is coming up in September. It's an 8-day program, and it is designed to actually provide people from the very beginning to the very end all the information that they need to understand this area. Word spreading, we know this. So then once people are educated, we can't accept their excuses anymore, because once we have given them the knowledge that they require and alleviated that ignorance, they cannot actually provide the existing excuses that they continue to. The second thing that I was looking at was looking at the prescribers. We've heard that the special access schemes have processes in place and that they're there for us to utilise. But I question the rigorous amount of documentation required that is designed, I believe, as an intentional barrier, because it's so damn time-consuming that people don't have time for this lengthy process. So we need to challenge why, when something is considered urgent, the system isn't simplified to fast-track people through the system who are needlessly suffering. Quite a few people that I know have the term KISS, keep it simple, stupid. Basically, let's just simplify this process. If the process is in place, we need to just design a guideline, not guidance, but a guideline that actually is going to be more simple to use to allow people in need who are suffering to access these schemes. If not, why don't we just start inundating every hospital and every doctor and every emergency room every single time an urgent need occurs? I've done this before and it works, because what happens is you can't deny care and emergencies are prioritised. So if this influx actually occurs quickly, without any respite, believe me, urgent attention to current processes will be demanded by the hospitals. as the very severity will not be able to be managed by their existing resources. So they'll be jumping up and down on our behalf as well. So these forces acknowledge that the processes are ineffective and we need to change that as well. Clinical-based research is a must. It provides data, evidence to support the benefits of medicinal cannabis and as a therapeutic alternative to the non-effective current traditional regimes. I'm a big believer in it. I'm an evidence girl. The medical community desire it. They want research completed by Australians in Australia on Australians. It meets proper procedure, it meets due diligence, and so therefore it can't be argued with. So yes, it seems stringent, but we need to remember that regulations are in place for a reason, and that is to prevent risk. So let's just bombard them with our clinical trials, with our research, and once that's provided, then they actually do have a duty of care and ethical responsibility to honour those results, or else be accused of denying assistance and permitting ongoing suffering and condoning neglect. That is a very serious allegation, and they won't like it because if we've got the resources to prove them wrong by our clinical research and our data, then they cannot ignore it. No matter what we do, the fourth point is that we must retain a healthy respect for any drug or medication inclusive of medicinal cannabis. We need to show that we are minimising risk. We cannot put vulnerable populations at further risk, and we need to do so significantly that the efficacy of medicinal cannabis cannot be challenged. So we do this by awareness of measured dose titrations, balance of cannabinoids or cannabidiol and THC based on biological need, examining the specific conditions being treated. So we identify the core root cause of an issue. We don't just look at the symptoms, we need to actually deal with the core. A multidisciplinary approach is also required when you use any type of medication. A medication is not going to be the only factor that assists people to heal. So we need to have overall treatment plans that complement the use of medicinal cannabis. Treatment of any condition can't be reliant just on the drug due to the individual variables contained in every single person. Considerations of age, nutritional needs, environmental factors, lifestyle can all also be adjusted to maximise life quality as well. We need that balance. So meeting that core root causative factors and needs may create then that ripple effect where effective treatment starts to manage all the other complications associated with any condition. So we provide a united front in advocating cannabis as an innovative solution and way forward within the pretty convoluted realms of modern medicine by challenging and dispelling those myths and attitudes associated with cannabis, reinforcing what we have recognised as the beneficial attributes associated with this organic plant. So now I'm going to launch into the research. I'm now the Director of Clinical Research for LeafCan, so I'm no longer part of Green Sea as was in the actual program. I'm very privileged to be working with a group of people who see it through the same eyes. They have the same ethos and vision as I do, and they come from that compassionate and united front. So I'm now working with LeafCan. We're also working with Ward Medication Management, who are a clinical pharmacology group in Australia, also focused in the aged care sector. And these guys are absolutely brilliant in regards to the pharmacology side of it, the scientific side of it, and the compounding. So together, we're going to be quite an enormously strong and powerful force. Okay, so we're looking at pain in the residential aged care sector. This is a significant, can everyone hear me when I walk around? Yeah. This is a significant area of need. I have worked in the aged care sector for 30 years now, and one of the areas that I've felt very helpless in is the fact that pain is so badly managed. It's one of those areas that nobody seems to get right. And my belief is that in this day and age, with all the alternatives that we actually do have, there is no excuse for people to live in ongoing, chronic, relentless, excruciating, debilitating pain for the rest of their life. It's a pretty harsh sentence to give anyone. And if we have the alternative to actually alleviate that, then there is no excuse to not go forward with it. We're looking at potent opioid analgesics as a factor that actually destroys quality of life. So, as you can see, they are widely prescribed, we know that, within the aged care sector, yet these agents are associated with the highest degree of drug-related harm. And then we have to take into consideration, because of all the adverse effects associated with the opioids, we're looking at a massive amount, a plethora of adjuvant medications that are also prescribed to help assist with counteracting all of the negative side effects of the opioid. So then you start looking at polypharmacy and cascading effects, which in turn start creating further debility and deterioration of this vulnerable population. Not only does it do that, but in 73% of cases, it also does not effectively manage their pain. What are we doing? Doesn't make sense. So I'm not going to read the abstract, it'll take me too long. I think that you've got a pretty good idea of what we're looking at. It is a critical and rapidly escalating problem. Gee, it's hard to look up there. Maybe I should look here. Pain has been recognised as a predominant and prevalent human encounter. No person is excluded from that. Most of us at some time in our life suffer pain from some form of condition. Maybe not in the chronic form, maybe not ongoing and relentlessly as a lot of people do, but we do have to acknowledge that pain is a significant encounter that most of us live with in our lives at some point, especially when we get to a certain age. It's considered one of the most poorly managed conditions due to the ineffective medication regimes we have in place. These medication regimes have been in place for so many years that it's about time that we stopped these rigid outlooks and started looking at the alternatives. It should be recognised that access to effective pain relief is a basic human right. If this integral right is disrespected, then this could be considered fundamentally neglectful towards those living with relentless pain. So we do need to start considering and looking at the alternatives. Chronic pain in the aged care setting is significant. Australia has a current population of about 15 million people. Over 300,000 are currently in residential aged care. Now, with the influx of the baby boomers, which we'll be talking about pretty soon, we're going to have an 80% increase in our ageing population. This is partly evolutionary, but it's also because we keep people alive for longer. So if we are keeping people alive for a longer period of time and the average age span is getting older by the moment, then we actually need to understand every single condition that is related to age being the greatest risk factor and actually manage them in a way that these people have a quality of life that enables them to live those golden years that we promise them, that actually alleviates their pain and the conditions that they suffer from on a day-to-day basis. Old age is truly not for sissies, okay? You've got to be pretty strong and you need to be a warrior to get through it. So it is up to us in the medical profession to assist them in every way we possibly can, because it's going to be us one day. The nature of aged care has changed in recent years. Ageing in place is something that's a lot more apparent. We do not have enough resources to care for this ageing population. The department has not been listening to us for the last 20 years and telling them to prepare for the influx of the baby boomers. And now they're sitting there panicking and floundering around and saying, we don't have enough resources, let's set up this framework, let's set up this plan. But it's too late because it's already started. So what we need to do is look at the fact that aged care, the face of aged care has now changed. Residential aged care has also changed because in the past, people used to go in at a lower acuity. There would be hostel level care and then there'd be nursing home level care, which was more terminal, late stage illness. Now, people are cared for in the home for much longer because there are a lot more aged care packages out there that enable people with physical ailments to be cared for longer at home. However, this doesn't meet the needs of our population. So when people go into aged care now, they're at a much higher acuity, so their needs are much more significant. So therefore, medication usage is more extensive and it creates that substantial potential for drug-related harm. We start that never-ending cycle again into deterioration and debility, and we're actually the ones that are causing that by polypharmacy and opioid regimes and actual medication cascading effects that actually aren't meeting their needs. Despite this, many have suboptimal control of their symptoms. Pain in residential aged care actually does come from a various amount of sources. We're starting off with musculoskeletal pain. Pain is so broad that you can't actually create clinical research or clinical evidence-based trials on pain on the whole spectrum because your data is not going to be viable. So we're breaking it down and we're looking at musculoskeletal pain first, then we'll move into neuropathic pain, then we'll start looking at pain associated with palliation and pain associated with oncology. And then we keep going from there because most conditions in the aged care sector and in the younger generation as well have pain as one of the signs and symptoms. So it will go on forever, probably way before I'm here to watch the rest of the research, but we'll just keep going with it as long as we need to. Chronic pain, the current options available. No. Yeah, I'm getting there. Yep. Non-pharmacological approaches, simple analgesia, intermediate potency analgesics, potent opioids, and then all the adjuvant medications that go with that. The bottom line is no solution is universally effective. All have limitations and problems, and many create as many problems as they fix. Did that change? I love this slide. Basically, what I've been seeing in my 30 years in aged care, and I think a lot of people have been seeing, is that we keep doing the same thing over and over and expecting a different result. Einstein said that that was the definition of insanity. So are we not quite insane to think that we continue these regimes and think that we're going to get a different result? Doesn't make sense to me at all. So he's a very smart man. Chronic pain in Australian aged care is a massive burden, contributes to overall suffering, debility, comes from different background of etiologies, as we know, is very especially difficult in the context of dementia and behavioural expression. People living with dementia lack the ability to verbalise pain, so a lot of times I don't, but a lot of people assume that people living with dementia aren't in pain because they don't verbalise it. That's a gross assumption. The other assumption they make is that they don't feel pain on the same level as a cognitively aware person. Another assumption. It's actually an absolute crock. So people living with dementia, because their needs are not being met, will exhibit behavioural expression to tell us that their needs are not being met. So we need to be very mindful that behavioural expression is an issue. The other issue is if people are left in excruciating pain for too long, they will then go into an acutely delirious state. Once again, we're exacerbating a condition that somebody's already suffering through by our inappropriate and unacceptable methods. I'm not even going to go through that. That is the Hughes stipulates the defined daily doses. We're looking at oxycodone, morphine, tramadol. Tramadol's not actually used as significantly as it used to be here in Australia. Oxycodone is our problem here. And this is, you'll see when you go through the actual presentation, you'll be able to look at the data there because I need to move through this pretty quickly. We know what the downsides of the opioids are in aged care: nausea, vomiting, constipation, potential for impaction, sedation, respiratory depression, tachyphylaxis, tolerance, drug interactions. Now, when you think about it, we're actually creating a situation for these people that creates a very neglectful deterioration, and we're not fixing the problem. So we need to actually look at this and see that what we're doing in a caregiving industry is providing a very uncaring attitude towards the people that we're supposed to be caring for. Thank you. These are the ward medication management go into aged care facilities, and they collect a lot of data on this, and this is what we've based our figures on, so I won't go through that either. A snapshot of the current state in Australia is, as you can see, oxycodone alone accounted for 24.1%, and the other areas are just commonly overused and overprescribed. These are all the adjuvant medications and the adverse effects, which I've also already talked about, so I'll flick through that. The new options we want to explore is obviously the very last one is to look at the available solution of using medicinal cannabis. We know that in this day and age that it can successfully manage pain. As discussed over the last 3 days, the specific compounds designed for these conditions can be maximised to create efficacy and minimise risk. We know that our bodies are hotwired to the endocannabinoid system, so we have coexisted with cannabis forever. So we also need to take this into consideration. So we need to believe that our argument is so compelling it cannot be ignored, challenge people why we are still wasting valuable time overthinking and demonising the healing properties of cannabis. No one ever got anywhere in the medical profession by playing it safe. So let's carve away all this rubbish to see the gem within and emphasise that this is an opportunity forward in modern medicine. Okay. And I'll just finish off with a nice little quote. Why is marijuana against the law? It grows naturally upon our planet. Doesn't the idea of making nature against the law seem to you a bit unnatural? And my favourite quote of all, be the change you want to see in the world, Gandhi. Thank you.